Hello everyone, welcome back to the class. Today we will talk about the facial symmetry and asymmetry. Symmetry may be defined as the correspondence in size, shape, and relative position of parts on opposite side of dividing line or median plane. Asymmetry is defined as lack or absence of symmetry. The application of this definition to human face illustrates an imbalance or disproportionality between the right and left side of the face. No human face exhibits perfect bilateral symmetry. Although a mild degree of asymmetry is no more unacceptable in the average face, greater degrees of asymmetry have been correlated with the clinical depression, low self-esteem, and other health problems associated with poor quality of life such as neurosis and an inferiority complex. A number of studies have been published in the psychology literature regarding facial asymmetry and perceptions of attractiveness. These studies report that the facial symmetry is an important factor in facial attractiveness. Perfect bilateral body symmetry seldom exists, and mammals in particular have marked asymmetry in the size, shape, and position of the internal organs. Brain function also exhibit asymmetry, a simple example being right and left-handedness. Craniofacial asymmetry may result from the discrepancies in the size, shape, or relative position of individual bones in the craniofacial complex and or the overlying soft tissue. Pegg and colleagues evaluated bilateral facial skeletal symmetry in 52 exceptionally well-balanced white Caucasian adults and observed that the degree of asymmetry was greatest in the lower facial third, and that asymmetry reduced as the cranium was approached. Severd and Profit analyzed the data from patients with dentofacial deformities over an 18-year period. Of the one-third that exhibited facial asymmetry, the lower facial third was affected much more frequently than the middle or upper thirds. Only 5% had asymmetry of the upper face, 36% had asymmetry of the mid-face, mainly just involving the nose, whereas 75% had a deviation of the chin. Facial proportions and facial asymmetry are separate yet interrelated entities. In fact, the classical Greek description of the symmetry and proportion are entirely interwoven. In the 1st century BC, the Roman architect Marcus Vultuvius Polio wrote the 10 volume of the Architectura in Book 3rd. The principle in that book that Vultuvius described for architecture were based on those described by the classical Greek sculptors. These same principles of the correct proportions and symmetry are the foundation of the diagnosis and treatment planning in the management of the craniofacial deformity. It is worthwhile remembering that a face may be disproportionate but symmetrical. But a well-proportioned face cannot exhibit significant asymmetry. The term balance and harmony are often used by clinicians when describing facial aesthetics. Left-right balance of the face refers to symmetrical relationships, whereas balance between the vertical facial thirds refers to the proportional relationships. The term harmonious proportions again refers to the ideal proportional relationships, whereas an harmonious facial profile often simply means a profile that is pleasing to the eyes. Both these terms are non-specific and in the clinical settings may serve to confuse. The term balance and harmony should ideally only be employed when the particular aspect being described is clearly specified. Otherwise, it is better to employ an accurate and quantifiable term such as symmetry and proportion when describing craniofacial morphology. Facial asymmetry may be caused by a range of factors that affect the underlying facial skeleton and or its overlying soft tissue. Regarding etiology, patients with a significant true skeletal and or soft tissue asymmetry may have a developmental condition or growth anomaly resulting from trauma. A complete patient history and medical history, in-depth clinical and radiographic assessment, and an evaluation of the developmental status in children will usually permit the development of the differential, if not definitive, diagnosis. Patients with congenital craniofacial syndromes are often relatively easy to recognize from the physical appearance. For example, hemifacial microsomia, craniosynostosis, Cruzon and Apport syndrome, and Treacher-Collins syndrome. Now we are to talk about the classification. A number of methods have been described to classify the numerous conditions resulting in facial asymmetry. Any attempt to bring order to such a group of disparate conditions is helpful, even if the various classifications cross-cut each other. A useful classification system involves broadly separating the causes of the facial asymmetry into three groups: congenital, developmental, and acquired. Congenital anomalies are conditions acquired during prenatal development, which are usually observed at birth and may be further subdivided into malformation, deformation, and disruption. A malformation is a morphological defect of an organ, part of an organ, or a larger area of the body, resulting from an intrinsically abnormal developmental process, for example, unilateral cleft lip. The earlier in embryogenesis such defects are initiated, the more complex the resulting malformation. A deformation is an abnormal form or position of a part of the body caused by non-disruptive mechanical forces. Finally, a disruption is a morphological defect of an organ, part of an organ, or a larger area of body resulting from a breakdown of or interference with an originally normal developmental process. Developmental anomalies are conditions arising during postnatal growth during adulthood. For example, mandibular asymmetry. Mandibular asymmetry is a potentially important factor in the perception of the facial attractiveness. Asymmetry of the lower third of the face often results from an asymmetrical growth of the mandible, which may be predominantly horizontal in direction, such as a hemimandibular elongation, or predominantly vertical hemimandibular hyperplasia, or a combination of the two. Acquired anomalies are conditions arising from either trauma or pathology. Examples of the pathological condition include condylar resorption due to juvenile rheumatoid arthritis. It is often results in a severe mandibular deficiency, which may be asymmetrical, or due to adult onset rheumatoid arthritis. Arthritic degeneration may destroy the condylar process, and the resulting deformities may be asymmetrical if one mandibular condyle is affected to a greater extent than the other. Okay, moving on to the clinical evaluation. When evaluating the craniofacial structures for asymmetry, the purpose of the clinical examination is threefold. One is qualitative analysis. It is identifying the specific locations of the facial asymmetry, whether skeletal or in soft tissue. Second, the quantitative analysis. It is objectively quantifying the degree of facial asymmetry. Having undertaken a thorough clinical examination, the third step is the craniofacial growth assessment. It is to determine, as far as possible, the location, magnitude, and direction of any further growth of the craniofacial complex. As with all systemic clinical facial evaluation, an overall qualitative visual anthroposcopic assessment is followed by a comprehensive quantitative anthropometric and cephalometric analysis. Having obtained the necessary data, a further qualitative assessment is carried out to determine whether the results of the quantitative assessment corroborate the qualitative evaluation. In other words, look at the patient, then measure the face, and then look at the patient again. In addition to the clinical examination, a full set of clinical photographs is also required. However, clinical photographs are not a substitute for comprehensive clinical evaluation but do permit further facial analysis to be undertaken and form a record of clinical observations. Generally, the clinical evaluation should begin with the frontal facial examination. The face must be examined for bilateral symmetry with the patient in natural head position, bearing in mind that a small degree of asymmetry is present in most individuals and essentially normal. The clinician may need to make minor manual adjustment to the patient head position, as patients will often have developed a compensatory head posture to minimize the aesthetic impact of their facial asymmetry, often tilting their heads to the right or left around the sagittal axis. Severe craniofacial asymmetries are notoriously difficult to assess as it is seldom possible to locate any bilateral symmetrical facial structures in order to provide a baseline. For example, the interpupillary plane from which to assess the asymmetrical structures. However, analysis of dentofacial asymmetry of the midface and in particular the lower facial third, such as the localized mandibular or chin asymmetries, may be more straightforward, particularly if the upper face third and orbits are relatively symmetrical and capable of providing baseline reference landmarks and planes, for example, the interpupillary plane. Facial midline. With the patient in natural head position, a true horizontal line may be drawn through the mid-glabella region, soft tissue glabella, midway between the eyebrows, perpendicular to a true vertical. For example, a plumb line from the ceiling. From this true horizontal line, a perpendicular facial midline or mid-sagittal plane may be constructed from the glabella. In less severe dentofacial deformities, the mid-philtrum of the upper lip or midpoint of the cupid's bow will commonly be in the midline of the face except in exceptional circumstances, such as cleft lip or severe nasal asymmetry distorting the upper lip. A line joining this point to soft tissue glabella forms the facial midline. In the symmetrical face, this line will extend to the midpoint of the chin, soft tissue pogonion. The midpoint of the nasal bridge and the nasal tip, pronasal, should be on this line if the nose is symmetrical. With the lips slightly separated, the maxillary and mandibular dental midlines may be assessed in relation to the facial midline, in particular to the mid-philtrum of the upper lip. Having obtained the patient's permissions, these points may be marked on the patient's face with a skin pencil in order to permit more accurate assessment. In patients with normal symmetry of the upper face and orbits and the absence of vertical orbital dystopia, a horizontal interpupillary line may be drawn which will be parallel to the true horizontal line. The next is vertical reference lines. Having established the facial midline, further vertical lines may be drawn parallel to the facial midline through any pair of bilateral landmarks suspected of being asymmetrical. It is then possible to assess the orientation of these lines in relation to the facial midline and the bilateral structures that they pass through, and the horizontal distance of each of the bilateral landmarks to the facial midline. The next is the horizontal or transverse reference lines. Horizontal reference lines may be constructed by connecting bilateral landmarks. It is then possible to assess if the lines are perpendicular to the facial midline, and the relative orientation of the various lines, which should ideally be parallel to one another with the absence of transverse cants. And finally, it is possible to assess the vertical level of bilateral structures to baseline horizontal reference lines, such as left and right calion, the angle of the mouth, to a horizontal line through a subnasal. Such linear measurements may be used anthropometrically or on facial photographs and three-dimensional facial soft tissue scans if landmark identification is reliable. In terms of the interpupillary lines, It is important to bear in mind that in some craniofacial anomalies, there may be significant vertical orbital dystopia. In other words, the orbital structures may be asymmetrical at different vertical levels. Therefore, in such patients, rather than use the interpupillary lines, it is necessary to draw a true horizontal line perpendicular to a true vertical line with the patient in natural head position. The presence of cant in the transverse occlusal plane may be observed in relation to the interpupillary line or a true horizontal plane with the patient biting on a wooden spatula or holding it against the maxillary teeth if there is a lateral open bite, both in the incisors and canine region and the premolar and molar region, or a Fox's occlusal guide plane. In the absence of transverse maxillary cant and/or vertical orbital dystopia, the transverse occlusal plane should be parallel to the interpupillary line. Following the frontal facial clinical examination, a symmetrical face may be evaluated clinically and photographically from a number of different views. The superior view is taken directly from the above and behind, with the patient's head hyperextended. This view is useful for assessment of the symmetry of the nasal bridge and the horizontal projection of the forehead, orbits, and particularly the zygomas and paranasal areas. Submental view. The submental view is taken directly from below with the patient's head hyperextended. This view is required to assess the symmetry of the mandibular body and the base of the nose, and is also useful for assessing any asymmetrical projection of the forehead, orbits, zygomas, and paranasal areas. Lateral view. The left and right profile views may be used to compare the contours of the left and right side of the face. This view is particularly useful for assessment of asymmetry in the contour of the inferior border of the mandible. Oblique lateral view or three-quarter view. These views are taken with the patient in natural head position and are useful for assessment of asymmetry of the nose, zygoma, and paranasal areas, and the mandibular ramus and body outline, including the gonial angle. Transverse occlusal plane view. This view is ideally taken with the patient in natural head position. An orthodontic cheek retractor may be placed in order to retract the lip and cheek. Alternatively, an assistant may stand behind the patient and retract the cheeks using photographic retractor. A transverse cant of the maxillary occlusal plane may be assessed in relation to a true horizontal plane or to the interpupillary plane in the absence of vertical orbital dystopia. And the next is the dynamic clinical evaluation. First is the mandibular lateral displacement. The basic position of mandible in relation to the rest of the facial skeleton is referred to as the rest position. The muscles acting on the mandible are in relaxed state and the condyles is retruded, unstrained positions within the glenoid fossa. This overall position is also referred to as the centric relation. In the rest position, the teeth are out of contact by 2 or 3 millimeters, referred to as the freeway space. When the teeth occlude into maximum intercuspation, the mandible should also be in a position of the centric relation. Ideally, the path of closure of the mandible from the rest position to the position of the maximum intercuspation of the teeth should be a simple hinge movement over the 2 or 3 millimeters of the freeway space, with the condyles rotating in their glenoid fossae. Occasionally, as the path of closure starts from the rest position, there is an initial premature contact of the upper and lower teeth. This is uncomfortable for the patient, necessitating a displacement of the mandible to obtain maximum intercuspation of the teeth. If this displacement or functional shift of the mandible is in lateral direction, the patient may exhibit apparent or pseudo-mandibular asymmetry. It is important to evaluate the mandible on opening and closing in order to check for displacements or functional shifts. Assess the patient from the front and then stand above and behind the patient as they open and close the mouth in order to assess any lateral mandibular movement on opening and closing. If a lateral mandibular displacement is present, the asymmetry should reduce as the patient opens the mouth, with the upper and lower dental midlines becoming better aligned. With long-standing mandibular displacements, the pattern of muscular activity is sometimes such that the displacement cannot be identified by observation alone. Therefore, if no displacement is observed, it is important to double-check by clinical manipulating the mandible into occlusion. Place the knuckles of your curled index finger under the patient's chin and your thumb on the mental eminence. Ask the patient to relax, then apply gentle pressure to move the mandible up and down, aiming to keep the condyle in the retrieved position within the glenoid facet. Look for the initial premature dental contact. The patient may be better able to identify this area and point it out to you. Having established the premature contact, ask the patient to bite together and the displacement will become evident. It is absolutely vital to check for mandibular displacement in case of mandibular asymmetry, as missing a lateral mandibular displacement may lead to the incorrect diagnosis of true mandibular asymmetry and inevitably incorrect treatment. It is also important to bear in mind that a patient may present with a combined true mandibular asymmetry and a lateral mandibular displacement. The degree of the true mandibular asymmetry must always be determined from the undisplaced position. Asymmetrical facial animation. Some asymmetry in facial animation is relatively common. It is important to note to mistake an asymmetry in facial animation with a dentoskeletal asymmetry. For example, an asymmetrical smile where the levator muscles of one side cause greater elevation of the upper lip than the contralateral side may be mistaken for transverse cant in maxillary occlusal plane. The next issue is the dental midline. Regarding maxillary dental midline, the upper dental midline should be aligned with the midphiltrum of the upper lip. Next, regarding the mandibular dental midline, the lower dental midline must be assessed in relation to the upper dental midline and to three anatomical related segments of the anterior mandible. The first is the dentoalveolar segment. The lower dental midline may be to the left or right of the facial midline due to dental crowding or spacing, causing lateral movement of the incisor teeth. The next is the body of the mandible. Asymmetrical growth of the mandible due to, for example, hemimandibular elongation will lead to a lower dental midline shift as the mandibular incisors are carried by the mandible. The last, the chin proper. Even in the asymmetrical mandible, the midpoint of the chin may be symmetrical or asymmetrically positioned in relation to the mandibular body. If the midpoint of the chin is symmetrical with the body of the mandible, in this case, even if the body of the mandible is asymmetrical, the lower dental midline needs to be corrected aligned to the midpoint of the mandible and chin. Surgical repositioning of the mandible to correct the facial asymmetry will thereby correct the dental midline discrepancy. Otherwise, if the midpoint of the chin is not symmetrical with the body of the mandible, the lower dental midline needs to be aligned with the midpoint of the mandibular body. When the asymmetrical mandible is surgically repositioned, the asymmetrical chin may be also repositioned by horizontal sliding genioplasty. It is important to distinguish between mandibular and isolated chin asymmetry. Asymmetry of the chin may be due to a true mandibular asymmetry, an isolated chin asymmetry, or a combination of the two. It is very important to differentiate between these during the clinical evaluation. With an isolated chin asymmetry, the relationship of the upper and lower lips is usually symmetrical. the oral commissure plane and a transverse occlusal plane will be parallel with the other horizontal planes of the face. In the absence of dental crowding or spacing, the dental midlines will coincide the facial midlines and with each other. When a mandibular asymmetry is present, the relationship of the upper and lower lips is often asymmetrical. The oral commissure plane and transverse occlusal plane are often canted and the dental midlines may not be coincident. The definitive diagnosis may be confirmed by the radiographic examination. It is critical to make a correct diagnosis. Moving on to the radiographic cephalometric evaluation, we will talk about the posterior-anterior cephalometric radiograph first. The posterior-anterior, briefly PA, cephalometric radiograph is indicated when a clinically significant facial asymmetry is evident. Analysis of this radiograph will permit the evaluation of any underlying dentoskeletal asymmetry. The first issue is the mid-sagittal plane. The first step in analysis is the identification of the mid-sagittal plane. A number of different methods may be used to establish a facial midline on the PA cephalometric radiograph. The first is a drawing of true vertical line in the facial midline. This is the recommended method. The radiograph must be taken with a very precise technique with the patient in natural head position, taking care to avoid the rotation of the patient's head about the sagittal or vertical axis. A true vertical line is drawn in the facial midline parallel to a plumb line hanging from the ceiling. Horizontal planes may be drawn perpendicular to this true vertical plane. The other method is constructing a midline perpendicular to a horizontal plane. It is possible to construct a horizontal plane by connecting bilateral skeletal structures and constructing perpendicular vertical line from a midpoint landmark. The problem with this method are the difficulty in determining which landmark or constructed point to use, and any small variation in the horizontal plane can produce a large deviation in the constructed facial midline. Harvard found that the zygomaticofrontal sutures and the Christagalli process of the ethmoid bone were relatively symmetrical structure compared to with other skeletal landmarks further from the cranial base. He recommended the construction of a horizontal plane through the lateral parts of the zygomaticofrontal sutures. The mid-sagittal plane may then be constructed perpendicular to this horizontal, passing through the root of the Christagalli. Harvard suggested that in 90% of the population, the anterior nasal spine will be less than 1.5 mm from these constructed midline. Connecting mid-sagittal landmarks. A number of midline landmarks may be identified and connected. However, these points will not always fall along the same vertical lines due to a number of reasons, such as the presence of the genuine facial skeletal asymmetry, or difficulty in landmark identification, or head rotation around the vertical axis in the cephalostat. Constructing midline landmarks by connecting the midpoints between bilateral structures. Selecting midpoints between bilateral structures creates midpoints that are not always in vertical alignment. These, therefore, cannot be used to construct a facial midline even in patients with relatively symmetrical faces, because faces are commonly asymmetrical with one side larger and wider than the other, and the rotation of the symmetrical head around the vertical axis in cephalostat. Finally, we can define the mid-sagittal plane by taking the radiograph with radio-opaque soft tissue markers. A number of soft tissue midline points, such as soft tissue glabella, soft tissue nasion, and pronasal, the mid-philtrum of the upper lip, and soft tissue pugania may be marked with metallic markers or barium cream prior to taking the radiograph. the dentoskeletal structures may be compared with the soft tissue midline. The construction and establishment of skeletal facial midline and mid-sagittal plane is important, but subject to many inaccuracies. The diagnosing clinicians must appreciate these limitations. And then, vertical reference lines and planes should be considered. Vertical reference planes may be used to illustrate the transverse skeletal asymmetry. Having established a mid-sagittal plane, further vertical lines may be drawn parallel to the mid-sagittal plane through any pair of bilateral landmarks suspected of being asymmetrical. It is then possible to assess the orientation of these lines in relation to the facial midline and the bilateral structures that they pass through, and the horizontal distance of each of the bilateral landmarks to the facial midline. This is possible but generally unnecessary, as there is a likelihood of forward or backward tilting of the head and or head rotation about the vertical axis, which will affect such linear measurement. Horizontal reference planes may be constructed by connecting bilateral landmarks such as the superior orbital margins, inferior orbital margins, and the left and right maxilla points, mastoid processes, maxillary molars, gonial angles, and the inferior border of the chin. These horizontal planes may be used to illustrate vertical dentoskeletal asymmetries. It is then possible to assess if the midline are perpendicular to the facial midline, and the relative orientation of the various lines, which should ideally be parallel to one another with the absence of transverse cants. And finally, the vertical levels of the bilateral structures to a baseline horizontal reference lines, bearing in mind that the use of such linear measurement of the PA cephalometry radiograph is somewhat unreliable due to the difficulty in landmark identification. And there are another analysis named as a triangular analysis. Vig and Hewitt described a triangulation method which may be used in the assessment of the skeletal asymmetry on a PA cephalometry radiograph. This approach has been modified by other researchers later. The first step is construction of mid-sagittal plane. A useful method for constructing a mid-sagittal plane on the PA cephalometry radiograph is the following, based on constructing a midline perpendicular to a horizontal plane. The first is a careful technique is employed in taking high-quality radiograph, particularly avoiding any rotation of the patient's head about the vertical axis. The next is the intersection of the lesser wing of the sphenoid bone and the median orbital ridge is marked bilaterally, and the points are joined to form a horizontal line. This is referred to as the cranial base plane or C-plane. Then a midline is constructed perpendicular to this horizontal line through the roots of the crista galli of the ethmoid bone. Having constructed the mid-sagittal plane, the midpoint of the horizontal C-plane is marked. Triangles may then be constructed to evaluate the symmetry of the maxilla and mandible and chin. The first is the maxillary triangle. This is constructed by connecting the midpoint of the horizontal C-plane with points MX, maxilla, the intersection of the lateral contour of the maxillary alveolar process and the inferior contour of the zygomatic process of maxilla bilaterally. The next is the mandibular triangle. This is constructed by connecting the midpoint of the horizontal C-plane with gonian bilaterally. Finally, the chin triangle. This is constructed by connecting the midpoint of the horizontal C-plane with the most inferior lateral point of the anterior-inferior border of the mandible bilaterally. Comparison of the long legs of the triangles demonstrates transverse cants of the maxilla, mandible, and chin in relation to the cranial base and to each other. This is another method of comparing the orientation of the horizontal planes, comparing the left and right halves of the base and of the bases of the triangles will indicate asymmetry and left-right difference in size. assuming no rotation of the patient's head about the vertical axis. When it comes to the lateral cephalometric radiograph, it must be taken with the patient in natural head position. If clinical examination reveals that the patient's auditory canals are not leveled in the vertical plane with the patient in natural head position, the cephalometric ear rods should not be used to reduce the possibility of the head rotation about the sagittal axis. Lack of superimposition of bilateral structures may be observed in patients with facial skeletal asymmetry. In particular, significant vertical differences between two separate inferior mandibular borders may indicate evidence of mandibular asymmetry, such as hemimandibular hyperplasia. We can use three-dimensional imaging evaluation. The thorough clinical evaluation of patients presenting with complex dentofacial and/or craniofacial asymmetries will be enhanced by the analysis of 3D records. The first and historical method is to assess the dental study cast. Dental casts of the occlusal are always useful when occlusal abnormalities are observed. Asymmetrical dental arch forms may be analyzed by placing a transparent ruled grid over each arch, with the grid axis in the midline oriented over the mid-palatal raphe, allowing direct observation of distortion in arch form. Dental casts are also useful in assessing whether any progressive changes to the dental occlusion are occurring over time, particularly in patients with mandibular asymmetries. In patients with hemimandibular hyperplasia, where a unilateral open bite or transverse cant of the maxillary occlusal plane is occurring, it is beneficial to mount the dental study cast on the adjustable articulator using a face-bow transfer. A face-bow is used to record the relationship of the patient's maxillary arch to the condyle hinge axis of the temporomandibular joints. The next is the three-dimensional facial soft scans, which is recently introduced. 3D facial soft tissue scans may be used to evaluate facial soft tissue morphology and to monitor asymmetrical growth by the superimposition of serial scans. The main advantage is no radiation exposure and the possibility of combining 3D computed tomography views of the dentoskeletal structures with a 3D soft tissue facial surface scan. Such technology is currently expensive and the system requires further development. Another frequently used method is the computed tomography. Information from CT scans may be used to provide two-dimensional localized views of the facial skeleton or 3D computed images that can provide excellent dentoskeletal detail required for the diagnosis of the complex dentofacial and craniofacial asymmetry. Vertical and horizontal reference planes, similar to those described for the PA cephalometric radiograph, may be employed in addition to other reference planes where landmarks identification is enhanced by the 3D image. Regarding vertical reference planes, the guidelines are similar to the PA cephalometric radiograph. Additional vertical reference planes may be constructed through the supraorbital, infraorbital, and mental foramina bilaterally. Regarding horizontal reference planes, these may be represented by the construction of a horizontal plane through the lateral parts of the zygomaticofrontal sutures or the intersection of the lateral wing of the sphenoid and the medial orbital ridge bilaterally. Further horizontal planes may be constructed through the following points: supraorbital foramen bilaterally, orbitae bilaterally, bizygomatic plane, zygomaticofacial foramen bilaterally, infraorbital foramen bilaterally, bimastoid plane, maxillary plane, maxillary occlusal plane, mandibular occlusal plane, bigonial plane, mental foramina plane, inferior border of the chin. In the symmetrical facial skeleton, these lines are nearly parallel. Inspection of the CT scan will allow the clinician to observe the relative orientation of these horizontal planes to illustrate vertical dentoskeletal asymmetries. The next and peculiar reference point are the trigeminal foramina. On a 3D CT, the vertical levels of the trigeminal foramina may be evaluated for symmetry. It is possible to construct a vertical line through the supraorbital, infraorbital, and ventral foramina, and also to connect the paired foramina to construct the horizontal planes for assessment. And data from the 3D CT scans may be used to fabricate a 3D stereolithographic dentoskeletal model of a patient. These models are particularly useful for diagnosis, treatment planning, and model prediction surgery in complex craniofacial asymmetrics. Finally, magnetic resonance imaging can also be utilized in the asymmetry analysis by 3D method. Magnetic resonance imaging may provide useful diagnostic information if there is a significant soft tissue element to facial asymmetry, particularly when caused by the pathological growth. Okay, we have talked about the facial asymmetry in detail. This is the end of today's lecture. Thanks for watching and stay tuned.